Hello, welcome to the introduction to workshop number 2 on alternatives to centralized care. My name is Megan, they, them. Up until April of this year, I had been living in Sweden myself and have tried to navigate various spaces of advocacy and education while completing my master's in Sweden. Now, I am presently a PhD candidate in education at the University of Waikato in Aotearoa, New Zealand, studying how we improve inclusive health delivery services to trans and gender diverse patient groups in a sustainable manner across 3 contexts. So I look at New Zealand, Canada, and Sweden within the lens of divesting power back to community members themselves to dictate their own trajectory of the future of trans healthcare needs. So, what is centralized care versus decentralized models? Centralized models of care involve the organization of healthcare delivery services into fewer specialized services as a strategy to increase the volume and variety of cases. It's meant to develop highly specialized services in relation to these complexities with an overarching goal to increase experience and efficiency and self efficacy of multidisciplinary teams. It's also meant to facilitate further training, limit costs, and reduce aspects related to clinical variabilities. In the most basic way of looking at it, it typically takes rare or complex conditions and arranges a space where these patient groups can go to have care received, but it comes with significant constraints, especially in context situations where countries with large land masses are a factor, or where we're seeing an exponential rate of increase to these patients groups that a specialized service cannot compete with the uptick in case referrals. In Sweden, centralized care, or NHV, fits into this definition, and Socialstraßen also defines it as occurring for rare or care that is complex and may be only conducted at a maximum of 5 units in the country. The purpose of concentrating this care is for the providers to be able to maintain competence in the entire disciplinary team, which is usually a subset of multiple team members, psychologists, psychiatrists, endocrinologists, etc., where they have the opportunity to develop and maintain a good quality of care without limiting accessibility. In Sweden, however, outside of national specialized care, it largely operates already on a decentralized model. Decentralized governance of health services means the transfer of authority in planning, management, decision making from a national level to a subnational level, which is usually giving the power back to regions or states or municipalities. Or in general, from higher levels to lower levels in the hierarchy of governance for healthcare. And decentralized governance of a healthcare system may encompass some of the typical functions of higher level government, such as allocation of central funds and recruitment of human resources for the actual health of the system itself. Authority for some functions may continue to remain centralized, while others are decentralized, depending on the type of need for that area. And typically, decentralization is a dynamic phenomenon with greater or less centralization of resources. So, in our pursuit of depatholization and how imperative it is to improve standards of care and our rights to self-determination and bodily autonomy, we already know from countries like Ireland, Denmark, Norway, and beyond that depatholization does not reduce wait times. In Ireland, for example, they are nearing 10-year wait times to access hormone replacement therapy, depending on the circumstances. And Sweden is steadily seeing the same patterns of wait time trajectory, yet still has a pathological gender law in place. Wait times in Ireland are largely caused by centralized care, reduced prioritization of resources, and lack of staff and awareness on care needs. So while we do emphasize the significance of depatholization, we must also decentralize care to impact how wait times can actually be reduced and quality of life improved. And to start by doing this, we also have to talk about change theory as a concept. So organizations or policies or departments that are adverse to change are often slow to recognize when there is a problem and may not recognize it until it's too late. And this inclination to avoid change in terms of making practice actually have real change can cause them to deny the need for change even as a crisis approaches. And we know that the crisis right now is wait times. And healthcare is a part of social protection in Sweden. The goal is to provide good health and care on equal terms, which follows Article 35 of the EU Charter of Fundamental Rights, but how it's executed by individual practices can be heavily inconsistent. And the main responsibility for approaches to decentralized care in Sweden reflects on how financing, organizing, and providing healthcare is delegated to the regions. The Ministry of Health and Social Affairs, with support from national government agencies, is responsible for the overall healthcare delivered at a policy level and in terms of providing oversight. Decentralization is one such public sector policy reform in which greater autonomy is provided to lower levels for one or more governmental services, including those levels responsible for health services. So, why decentralized care? Health system decentralization has been implemented in different forms and to different extents depending on a variety of political and public administrative structures across the globe in many contexts, and especially in countries where wait times for trans care are weeks instead of years. We see that decentralized models exist. So decentralized care serves to empower healthcare professionals to have more autonomy and flexibility on decision-making capacities on areas of care they're already comfortable with or wanting to learn more in regards to conditions they may not be comfortable with. It ensures open communication and resources that are available to provide immediate healthcare delivery with patient groups with needs. It is no different than what healthcare professionals already do in Sweden. Eliminates uneven power dynamics, dictate the only experts available in trans care disciplines are those in gender clinics, which creates systemic accountability issues. It eliminates viewing trans and gender diverse patient groups as othered from cis patient groups, where providers already treat complex hormone-related conditions for, eliminates repeated instances of trans broken arm syndrome. It addresses how gender clinics have identified a lack of confidence in how centralized care will properly address consistent care, lack of resources, etc. Especially since gender-related care has already been centralized in Sweden for a very long time. It enables more patient-centered experiences in care, which improves patient outcomes and life satisfaction factors. It ensures access for patients in more difficult rural locations to access care without taking time off to travel to clinics. It integrates more opportunities for continued education and ultimately can lead to a reduction in discriminatory cisnormative behaviors from healthcare providers perpetrated onto patient groups. With the caveat that some aspects, like the current state of gender-affirming surgical care, should still be centralized, but other things don't need to be. So how do we decentralize care? It should happen in tandem with depathologization, as we've already sort of talked about. It ensures that patient groups can access gender-affirming care through their primary health providers, such as at a central level, and enabling successful inclusion of practices and management resources for conditions with similar endocrinological nature of cis patients that they already deal with. Hormonal therapy, in fact, has few serious side effects, although you will still find long list of contraindications and safety measures in current guidelines. This is no different than other regularly distributed medications that require follow-up. But the successful execution of trans health services on a decentralized model already exists globally, and it is capable of being implemented in Sweden. Resources and guidelines are largely available already to providers in Sweden for different conditions, and it's not a difficult stretch to close this gap. This can also involve stepping into this century of informed consent models and e-health or telehealth availability, which could open up prospects for this group to have accessibility options related to care without having to travel, and increasing the resources available by involving providers across the country rather than just centralized gender clinics. For those working in trans care across the EU, it has also been stated how important this is, especially in terms of seeing a decentralized delivery of care as more client-centered in terms of involvement in care, shared decision-making, and empowerment. It can't only be patients advocating for this, but healthcare providers and admin leadership too and beyond. So, when we're starting to look at how to improve centralized care and decentralize it, some of the things that we can ask ourselves are looking at models of improvement and saying, what are we trying to accomplish? How will we know that a change is an improvement? What changes can we make that will result in an improvement? And then from here, going into the principles of improvement. And this is very basic. There's lots of ways to have this conversation, but thinking about knowing why you need to improve, having a way to get feedback to know that an improvement is happening, developing a change that you think will result in the improvement across a decentralized model, testing this change before making an improvement, and then implementing it at a larger scale. And this is a very long-winded way of saying decentralized care is possible. And as you're having these conversations across this workshop with your wonderful facilitators, try to remember that change from a theoretical point of view is largely about dismantling your own unconscious biases. And that's something that has, just because something has existed for a long time, does not necessarily need to continue to be the way that it is, to be seen as progressive. We tend to get very stuck in our status quos, and that it's okay to learn from others to see what works across different countries. Ultimately, if you remove the barrier of needing to see specialist clinics for simple gender-affirming care like hormone replacement therapy, it would greatly instill confidence back into the healthcare system, both from service users to service delivery individuals, and would create less confusion in the healthcare system overall and ensure that we're not seeing inhumane wait times like we are at present. It, in proper implementation of self-determination, would mirror systems that already exist around the world, including your neighboring countries, and have not failed because of this adaptation. So I really hope that you can enjoy your time today, and thank you for your time listening right now.